This presentation, about the neuromuscular blockers, is prepared by Professor Mohammed Abdelbari, Professor of Pharmacology, and Shamas Faculty of Medicine. The prepared narration is read by the Microsoft David voice. This presentation is divided into two parts. By the end of the first part, the student should achieve the following intended learning outcomes, or in other words, he should be able to 1. Classify the neuromuscular blockers into two main groups, and list examples in each group. 2. Differentiate between the mechanisms of action of each group. 3. List the various methods of elimination of the different members of the neuromuscular blockers, and relate each mechanism to the duration of action of each one. 4. Apply his understanding of the mechanism of action, and methods of elimination, to explain or take a decision in some of the clinical situations, related to the neuromuscular blockade. The first intended learning outcome, is concerned with the classification of the neuromuscular blockers, based on their mechanism of action. We have two main groups. The first is the depolarizing, or the non-competitive group. This group induces NM receptor blockade, by overstimulation, or in other words, by inducing persistent depolarization. In the normal sequence of NM receptor activation, acetylcholine induces depolarization, which activates the receptors once. When the acetylcholine is metabolized, the depolarization disappears, and the receptors become ready for reactivation more and more times. However, in case of the depolarizing neuromuscular blockers, the drug is not metabolized rapidly as the case with acetylcholine. Accordingly, the depolarization persists, and the NM receptors will be activated only once. After this initial activation, the acetylcholine will not be able to activate the receptor again, because it is in a state of persistent depolarization, thus paralysis will ensue. The only example of the depolarizing neuromuscular blockers is the succinylcholine. It is made of two molecules of acetylcholine attached back to back. However, we still have two examples that act only in roundworms. 1. Pyrantel pamuate, which causes the release of acetylcholine, and inhibits its degradation by the cholinesterase enzyme. The excess acetylcholine acts as a depolarizing neuromuscular blocking agent, thereby causing sudden contraction, followed by paralysis, of the helminths. Since pyrantel is poorly absorbed by the host's intestine, the host is unaffected by the small dosage of medication used. 2. Levamisole. It has an agnostotic activity towards the L subtype nicotinic acetylcholine receptors, which are present only in nematode muscles. The second is the non-depolarizing, or the competitive group. The neuromuscular blocker in this group competes with the acetylcholine for the NM receptors. Chemically, they are classified into two subgroups. 1. The isoquinolines, that is, their structure contains at least one isoquinoline group, which consists of a benzene ring, fused with a pyridine ring. The most famous example is the alkaloid D-tubocurarine, which is coined the famous name, curare. It also contains the famous blocker, atracurium, and its chemical isomer, cis-atracurium. Recently, gonticurium is added to this subgroup. Second, the steroids, that is, their structure contains the famous cholesterol nucleus. It contains many drugs, e.g. V-curonium and Ru-curonium, pancuronium, galamine, and many others. The second intended learning outcome is concerned with the mechanism of action of the neuromuscular blockers. Let us start with the depolarizing group, that is the succinylcholine, or succinylcholine. This is the cell membrane at the motor end plate, or simply the MEP. This is the site of junction between the motor cholinergic nerve, which releases acetylcholine, and the sarcolemma of the skeletal muscle, which contains the nicotinic NM receptors. This is a longitudinal section of the nicotinic ion channel. It shows 2 of the 5 subunits of the nicotinic ion channel, the first alpha subunit, and the delta subunit. The ion channel is closed at rest. The extracellular fluid contains excess of the sodium ions, and the intracellular space contains excess of the potassium ions. This is the molecule of succinylcholine, which is made of 2 acetylcholine molecules attached back to back. Based on its similarity to acetylcholine, succinylcholine binds to the acetylcholine binding site on the NM receptors. It stimulates the receptors, the same as acetylcholine, leading to opening of the ion channel. This channel is a mixed sodium-potassium channel. Accordingly, some of the excess extracellular sodium moves along its concentration gradient to enter the cell, and at the same time, some of the excess intracellular potassium escapes outside the cells. This results in slight depolarization at the motor end plate, since the positive charge on the sodium ions exceeds the positive charge on the potassium ions. This depolarization is called the end plate potential. It is about 5 to 15 millivolts. It triggers action potential in skeletal muscle, and thus initiates skeletal muscle contraction. However, unlike the acetylcholine, the depolarization is persistent, since succinylcholine is not metabolized by the true choline esterase enzyme, which is present at the motor end plate. Rather, it has to diffuse away from the receptors, to be metabolized by the pseudocholine esterase enzyme in the plasma. This persistent depolarization is termed phase 1. When succinylcholine diffuses away from the receptors, and is metabolized by the pseudocholine esterase enzyme, depolarization disappears. The nicotinic ion channel recloses, and the membrane potential returns to the resting level. This is termed repolarization. If the NM receptors is further exposed to excess of the succinylcholine, it can still bind to the acetylcholine binding site. However, it fails to stimulate the receptors. As if, the receptors are in a refractory period. They are no more sensitive to acetylcholine, despite full repolarization. This is called repolarization blockade, or phase 2. To summarize the mechanism of action of succinylcholine, or the depolarizing group of the neuromuscular blockers, there are 2 phases. Phase 1, where succinylcholine binds to the NM receptors, to induce persistent depolarization. This leads to initial skeletal muscle contraction, called fasciculations, followed by flaccid paralysis. Phase 2, where excess succinylcholine binds to the receptors, but it cannot induce further depolarization, because the NM receptors are in a state of desensitization blockade. The flaccid paralysis induced by phase 1 continues. Phase 2 exactly resembles the competitive group, where the drug is bound to the receptor, and prevents binding of the acetylcholine. Now, the second group, the non-depolarizing, or the competitive group. This is the NM receptor at the motor end plate. And this is the nerve ending of the motor nerve. It contains acetylcholine molecules, represented by the red triangle inside the nerve ending. This is the most famous example of the non-depolarizing group of neuromuscular blockers, D2-bocurarine, or simply the curare. It binds to the acetylcholine binding site, but it fails to stimulate the NM receptors, that is, it acts as an antagonist. Acetylcholine fails to bind to the NM receptors, in presence of curare. This is accompanied with decrease in the power of contraction of the skeletal muscles on motor nerve stimulation. This occurs at small doses of the non-depolarizing neuromuscular blockers, where curare competes with acetylcholine to the binding site at the NM receptors, and it succeeds to displace it, or to prevent its binding. In large doses, curare has two additional actions. First, it blocked the nicotinic ion channel, in addition to its blocking effect for the NM receptors. Second, it blocks the presynaptic nicotinic NN receptor, which is responsible for facilitation of acetylcholine release. This leads to progressive decrease in acetylcholine release from the motor nerve, with subsequent fade in the tetanic contraction of the skeletal muscle. The third intended learning outcome is concerned with the elimination of the neuromuscular blockers, and its relation to the duration of action of these drugs. Actually, the action of the neuromuscular blockers is terminated when these drugs diffuse away from the nicotinic receptors. However, elimination helps the drug to leave the receptors, by decreasing the concentration of the drug in the blood, and thus, invites the receptor-bound drug to diffuse away from the receptors, and enter the bloodstream. The most rapid way of elimination is by hydrolysis of the neuromuscular blockers. This can occur by one of two ways. The first is enzymatic hydrolysis, and this is very fast, since the enzymes usually accelerates the chemical reactions. The most famous enzyme involved in the metabolism is the pseudocholine esterase enzyme. The second is the non-enzymatic hydrolysis, which is also called Hofmann reaction. This is a little bit slower than the enzymatic hydrolysis. However, it is beneficial in presence of liver or renal diseases. The pseudocholine esterase enzyme can metabolize drugs which resemble acetylcholine, e.g., the choline ester succinylcholine. Succinylcholine is the shortest acting neuromuscular blocker. Its action does not exceed 10 minutes. The pseudocholine esterase enzyme can also metabolize the competitive drug, mivacurium. However, it has slower onset of action, and it acts for 10 to 20 minutes, due to its slower interaction with the nicotinic receptors. The non-enzymatic hydrolysis occurs for the competitive member, gonticurium. Although the hydrolysis is slower than the succinylcholine, still it has similar duration of action, since its hydrolysis is preceded by cysteine adduction, which rapidly terminates the action of the drug. Chemically, adduction means binding of two molecules together, without losing any part of each one. Similarly, atracurium is metabolized by Hofmann reaction. It has a duration of action that ranges between 20 and 30 minutes. One of the atracurium metabolites is called laudanosine. This metabolite is slowly eliminated by the liver. On prolonged administration in ICU, it may accumulate, crosses the blood-brain barrier, and induces seizures. The release of this metabolite is less with cisatracurium. Another method of elimination is through hepatic metabolism. Hepatically metabolized drugs usually have moderate duration of action. Vicuronium and rucuronium act for 20 to 30 minutes. However, a drug called sugammadex may be used to terminate the action more rapidly. It binds with the drug, and the complex is then slowly excreted by the kidney. Thus, rucuronium may have a duration of action comparable to succinylcholine. Pancuronium has a dual mode of elimination. About 45% of the dose is metabolized in the liver. It has a duration of action between 30 and 45 minutes, since it releases an active metabolite, which is 40 to 80% as potent as the parent drug. The last method of elimination is through renal excretion. This is the slowest method of elimination. Ditubocurarine and golamine act for more than 45 minutes. About 55% of pancuronium is also excreted by the kidney. This presentation about the neuromuscular blockers is prepared by Professor Mohammed Abdelbari, Professor of Pharmacology, and Shamas Faculty of Medicine. The prepared narration is read by the Microsoft David voice. By the end of this second part, the student should achieve the following intended learning outcomes, or in other words, he should be able to 1. List the indications of the neuromuscular blockers, specify which neuromuscular blocker is the best for each indication, and give reasons for his choice. 2. Enumerate type A, or augmented adverse effects of each group, explain the underlying mechanism of each adverse effect, and list the interventions to correct each one. 3. List the 2 most common type B, or bizarre adverse effects, explain the underlying mechanism for each one, list the predisposing factors, and list the lines of management, giving reasons for choosing each line. The first intended learning outcome is concerned with the indications of the neuromuscular blockers. These drugs are commonly used by the anesthesiologists, as well as in the intensive care units. The first indication is for endotracheal intubation, which is an essential step before general anesthesia. These drugs relax the skeletal muscles of the larynx, including the skeletal muscles of the vocal cords. This facilitates introduction of the endotracheal tube, through which the inhaled anesthetic is going to be administered. The best, and the most commonly used drug, is the shortest acting one, e.g., succinylcholine. Usually, the induction starts by a short-acting anesthetic, e.g. intravenous thiopental. This anesthetic will act for about 10 to 15 minutes. When the patient loses his consciousness, the succinylcholine is injected intravenously. This leads to paralysis of all the skeletal muscles, including the respiratory muscles. The endotracheal tube is introduced rapidly, and the patient is ventilated through it, until the action of succinylcholine vanishes. At the same time, the inhalation anesthetic is introduced, mixed with oxygen, to continue the effect of the thiopental, which was used for induction. The second indication is to control convulsions, during which there is persistent skeletal muscle spasm, involving all the skeletal muscles including the respiratory muscle. These drugs are not of choice, but they are the last choice, if all the other alternatives fail. Actually, the drug of choice is the diazepam, which is a sedative hypnotic, and not a neuromuscular blocker. Convulsions can harm the patient, starting with traumatic injuries and ending with arresting the respiration. Again, the best drug is succinylcholine. One of the most important indications is muscle relaxation during intracavitary operations, e.g. intra-abdominal and intrathoracic operations. They are needed if there is muscle-cutting incisions. That is, incisions which cut across the direction of the muscle fibers, since the cut edges of the muscle will retract towards the origin and the insertion, which make future suturing difficult. Pancuronium is the most commonly used drug, if the liver and the kidneys are normal. However, in presence of renal or hepatic diseases, cisatracurium is the preferred one, since it is eliminated non-enzymatically. In presence of cardiovascular diseases, vicuronium, or rucuronium, are preferred since they offer cardiovascular stability, and their actions can be easily terminated with sugammadex. The last indication is to control ventilation. This is needed in the ICU, when the patient is suffering from a serious respiratory problem, and artificial ventilation is indicated. In this case, a competitive drug, as cisatracurium, is administered by intravenous infusion for long times. This reduces the chest wall resistance, as well as the ineffective spontaneous ventilations. The last two intended learning outcomes are concerned with the adverse effects of the neuromuscular blockers. Let us start with the adverse effects of the competitive, or the nondepolarizing group. The most traditional one, the D2-bocurarine, has three groups of adverse effects. All are type A adverse effects, that is, they are expected, and they are augmentation of a known pharmacological action. The first one results from prolonged muscle paralysis, which occurs secondary to prolonged nicotinic MN receptor blockade. It may present as prolonged apnea, after the end of the surgical operation, or as prolonged muscle weakness, leading to annoying symptoms, e.g., facial paralysis or diplopia from weakness of the extraocular muscles. The action of the completive neuromuscular blocker can be terminated by subcutaneous neostigmine, preceded with glycol pyrrolate, or atropine, to control its muscarinic adverse effects. In addition, the action of rucuronium and to a lesser extent, vicuronium, and pancuronium, can be antagonized by sugammadex, which encapsulates the drug, and helps its renal elimination. Cysteine can also reverse the action of gonticurium. The second one results from the alkaloid nature of the drug. It can release histamine from its binding granules, leading to manifestations similar to allergy. These manifestations may be minor in the form of skin rash, or may be serious, in the form of bronchospasm, especially in asthmatic patients. The third one is hypotension. This may be a problem, since it adds to hypotension secondary to bleeding during surgical operation. Many factors contribute to this hypotension. 1. muscle paralysis, since the muscle contraction is needed to maintain the venous return. 2. Additional ganglionic NN receptor blockade, which attenuates the sympathetic tone. 3. Histamine release, which is a very potent vasodilator. In an attempt to decrease the above-mentioned adverse effects, other neuromuscular blockers are introduced. These include pancuronium and galamine. These agents have moderate risk of histamine release, but they have atropine-like adverse effects, including tachycardia and hypertension, rather than hypotension. The newer agent largely eliminated most of the annoying adverse effects of D2-bocurarine. They have no ganglionic blocking activity. Moderate risk of histamine release, as with atracurium, or minimal risk of histamine release, as with cisatracurium, rucuronium, and vicuronium. In fact, the safest neuromuscular blocking agents, on the cardiovascular system, are these last three drugs. Now, the adverse effects of the non-competitive, or the depolarizing group, that is succinylcholine. These may be divided into two major subgroups. First, is the type B, the bizarre adverse effects, or the pharmacogenetic adverse effects. These include the succinylcholine apnea and the malignant hyperthermia. The discussion of these two idiosyncratic effects will be deferred to discuss each one in more details. The second is the type A, the augmented adverse effects. 4 of these adverse effects stem from the persistent depolarization. The first is muscle pains, which occur due to the non-synchronized contractions, or fasciculations that occur initially before the muscle paralysis. These may be abolished by priming with a small dose of a competitive agent, before succinylcholine. This adverse effect may be serious in patients with extensive muscle trauma. The second is the increase in intraocular pressure, which occurs due to fasciculations in the extraocular muscles. This is a minor adverse effect. However, it may be serious in presence of penetrating eye injuries, where the increased intraocular pressure may push the eye contents to the outside. The third is the hyperkalemia, which occurs due to prolonged opening of the skeletal muscle ion channels. Potassium escapes from muscle, and this may induce serious ECG changes, which progress to arrhythmia. For this reason, succinylcholine is not used in surgical operation in heart failure patients treated with digoxin. The last one is vomiting, which is attributed to the fasciculations of the abdominal muscles. Other adverse effects stem from the additional receptors effects, e.g., the bradycardia, which occur due to muscarinic receptors stimulation. Now, the last item in the lecture, the two idiosyncratic adverse effects, or the pharmacogenetic adverse effects. Let us start with succinylcholine apnea. Apnea is expected with any neuromuscular blocker, as it is an extension of its pharmacological action. However, in case of succinylcholine, it is expected to persist for about 10 minutes. What is unexpected is that it persists for many hours. In such case we call it succinylcholine apnea. The cause of the persistence of the apnea is that a large amount of the succinylcholine dose reaches the nicotinic NM receptors, because there is a problem with the pseudocholine esterase enzyme. The enzyme may be totally absent, or genetically defective. It may be present, but is deficient due to hepatic diseases, since the liver is the main site for its synthesis. It may be also present, but is not working, due to recent exposure to an anticholine esterase agent. The most common type is the organophosphorus insecticides. Theoretically, we can estimate the anticholine esterase activity, before administration of succinylcholine, by measuring the dibucane number. Dibucane is an ester local anesthetic, that is hydrolyzed by the pseudocholine esterase enzyme. So, we can test a sample of the patient's blood, to estimate the dibucane number. Anyhow, this is not practical, nor applied clinically. The best solution is to continue artificial respiration, as long as the apnea is present. This gives a chance for the high succinylcholine concentration to diffuse away from the nicotinic NM receptors. If there is a history of succinylcholine apnea, we may give fresh frozen plasma, or fresh blood transfusion, before the surgical operation. This supplies enough amount of the enzyme to metabolize the succinylcholine. The second idiosyncratic, or pharmacogenetic adverse effect is the malignant hyperthermia. The term malignant is coined to indicate that this adverse effect is very serious. The patient's skeletal muscles are thrown into persistent spasm, with generation of huge amount of heat, that raises the body temperature to very high levels. This usually occurs few minutes, up to 2 hours after induction of anesthesia, that is, the patient is usually on the surgical table. The predisposition to malignant hyperthermia is inherited as an autosomal dominant trait. I.e., if the two parents are affected, all the children will be affected. And if only one of the parents is affected, 50% of the children will be affected. The abnormal gene is present on chromosome number 19. The only treatment is a drug called dantrolene. This drug decreases the calcium release from the sarcoplasmic reticulum, since the abnormal biochemical mechanism underlying the malignant hyperthermia is massive calcium release, on exposure to succinylcholine, or the general anesthetic halothane, or both. To save the patient's life, dantrolene should be given as soon as possible, and repeated as needed. The last intended learning outcome is concerned with the clinical implications of the mechanism of action, and the elimination. Why succinylcholine induces initial muscle contraction before inducing paralysis, while the nondepolarizing group induces flaccid paralysis from the start? The answer: this is because succinylcholine induces initial depolarization, which stimulates skeletal muscle contraction. Since each fascicule of the muscle contracts independent of the others, these contractions are not synchronized, and are termed fasciculations. These initial fasciculations are followed by flaccid paralysis, since no further depolarization can occur. On the other hand, the competitive group do not induce any depolarization, rather they inhibit the acetylcholine-induced depolarization, that is, they induce flaccid paralysis from the start. Why drugs which increase acetylcholine level augment the action of succinylcholine, while they reduce the action of nondepolarizing group? The answer: acetylcholine induces depolarization, the same as succinylcholine during phase 1 of its action. However, the nondepolarizing group, as well as succinylcholine during phase 2 of its action, inhibit depolarization, and accordingly, the action is antagonized by acetylcholine. What is the effect of deficiency of pseudocholine esterase enzyme on the action of succinylcholine? The answer: pseudocholine esterase enzyme can metabolize any choline ester including succinylcholine. Thus, it destroys most of the injected dose of succinylcholine before they reach the skeletal muscle. The part of succinylcholine which escapes this metabolism is responsible for the action of this drug. If the pseudocholine esterase enzyme is deficient, most of the dose will reach the skeletal muscle, leading to prolonged paralysis. Is the persistent depolarization of succinylcholine useful or harmful? The answer: the persistent depolarization induced by succinylcholine leads to prolonged opening of the sodium-potassium ion channels. Escape of the potassium from the skeletal muscle may be serious. Why the alkaloid, competitive neuromuscular blockers, can release histamine? The answer: the alkaloids are basic compounds, similar to the histamine. They compete with histamine and replace it in its binding granules. The released histamine can induce serious reactions, similar to the allergic reactions which are mediated by histamine. Can the neuromuscular blockers act on other cholinergic receptors? The answer: yes. Succinylcholine may stimulate muscarinic receptors, the same way as acetylcholine. This is responsible for the cholinomimetic adverse effects of succinylcholine. Curare-like drugs can block the nicotinic NN receptors, which are present in two sites: first, presynaptically on the motor nerves, thus, they progressively decrease acetylcholine release. During tetanic contraction, this phenomenon is called tetanic fade. Second, on the autonomic ganglia, this leads to blocking of the sympathetic discharge, which may aggravate hypotension during surgical operations. The only exception of this is pancuronium, which stimulates, rather than block the nicotinic NN receptors. Two of the curare-like drugs, pancuronium and galamine, additionally block the muscarinic receptors, that is, they have atropine-like actions. What is the shortest acting neuromuscular blocker, and what is the clinical implication? The answer: the shortest acting neuromuscular blocker is succinylcholine. This makes it the drug of choice if short duration of paralysis is needed. However, if there is a contraindication for succinylcholine, we may give roucuronium followed by sugammadex to terminate its action. Another more or less similar short-acting one is gontacureum. Still, we can also shorten its action by giving cysteine. What is the longest acting neuromuscular blocker, and what did you do if you still need a longer duration of action? The answer: the longest acting neuromuscular blocker is D-tubocurarine, which is eliminated by the kidneys. However, we usually give a non-depolarizing agent, e.g. cisatracurate, by intravenous infusion, if a long duration of action is needed. What are the neuromuscular blockers that can be used if there is a problem in the eliminating organs, the liver, or the kidneys? The answer: we can use the drugs that are eliminated by non-enzymatic hydrolysis, e.g. atracurate, cisatracurate. Drugs which are eliminated by pseudocholine esterase may be also used, however, their duration of action may be prolonged, since the level of pseudocholine esterase is lowered in presence of hepatic diseases and in renal failure. Why cis-atracurium is preferred to atracurium? The answer: it is preferred for two reasons. First, it induces less histamine release. Second, the accumulation of the metabolite, laudanosine, is less on prolonged administration. This metabolite may induce convulsions, and it also increases the anesthetic dose used. Why gonticurium has shorter duration of action than atracurium, although its hydrolysis is more slowly? The answer: gonticurium has shorter duration of action, since its action is terminated by cysteine adduction. The slow hydrolysis has nothing to do with the termination of action, though it is needed to get rid of the drug later on.